I'm Dr. Rudy Cashman, neurosurgeon in Fort Wayne, Indiana, for 42 years. But I have with me tonight 3 guests, and we total 130 years of experience. Unbelievable. And the subject tonight is addiction, a very important problem across the whole nation, but especially in Fort Wayne, Indiana. And the first thing I'd like to go through just for a second here is what is addiction? If you're taking a substance and you feel a craving for it, it's 3 or 4 things out of 10, and I'll go through these quickly. One is that you have a craving for a substance. Could be food. Addiction is not just narcotics. It's also food or gambling or alcohol or cigarettes. So all addictive. Number 2 would be that you feel some withdrawal symptoms. In other words, you use a substance and you feel like something isn't right. Something is changing in my body. That would be withdrawal symptoms. And thirdly would be that if you take the same substance and it relieves those symptoms of withdrawal, that would be number 3. Number 4 would be that you develop a tolerance for it, that over time you constantly seem to be having to take a larger dose of it. Could even be food. You could be addicted to food. It's extremely addictive, so that you're constantly raising the level of the narcotic or the food or cigarettes as part of the process. And then number 5 would be that you have repeated failures. You try to stop it and stop eating so much, stop smoking so many cigarettes, drinking so much alcohol, taking so much narcotics, and you just can't get the job done. You just keep on failing. Number 6 would be that now it's starting to affect you socially. You're going to social events and you're in company of people that do similar things to you and you're attracted to them. So social failures are common. And then next, now you begin to notice it's starting to affect your work. You're missing days at work. And it's because you're using the substances from narcotics to alcohol to whatever. And the next step would be you're starting to get in trouble with the law. You're getting arrested now and then. You're starting to steal the medications when you're visiting the grandparents or getting into other people's cabinets. Some even break into homes. That's the addictive process. And if you have, say, 3 of those or 4 of those, you're an addict. You're an addict. And with that, let's pump our 130 years of experience here. And I'd like to introduce these wonderful people I have with me. I have Teresa Yarrell here, who is a recovery counselor at AADP, a wonderful organization in town founded over 30 years ago. And to my right is Dr. Ronald Pantz, a psychiatrist, who is one of the founding fathers of this great organization. He has as many years of experience than I do. Actually, he's a year ahead of me, I think. And then thirdly, Dr. Phil Shorten, who is a counselor at AADP, a man of many years of experience. And with that, let's start the discussion here a little bit. So tell me, Teresa, your experience a little bit. What are you looking at these days, largely? What the most common addictive substances that you're dealing with?
Well, some of the substances, and it used to be alcohol, used to be the primary, marijuana, cannabis, but what we're looking at, and I think that we have discovered that, and through the agency or the collection of agencies, we're finding that prescription medication is coming up in second, where the benzodiazepines, the opiates, the Valiums, the heroines, opiate is fastly taking up the pace on addictive substances in our community and across the nation. It's something that we need to be aware of. When I first started out in this field, alcohol, cocaine, and marijuana. Now we're looking at people that are abusing or becoming dependent on prescribed medications. We're also seeing in our community the synthetic, the K2 spices, the bath salts, the methamphetamines, heroines coming in back into our community, and those are things that we need to be aware of.
I'm particularly concerned because opium and the opiates have come to the point that more people die from overdoses on those substances than get killed in traffic accidents. So it's become a national crisis and an epidemic. And I think part of it is due to the history of pain relieving, because I can remember about 15, 20 years ago, the government was saying that doctors aren't paying enough attention to alleviate pain. So all of a sudden, doctors started paying more attention. The only problem is that doctors don't have much training in using pain medications. I can remember very little time spent in my residency or my time in internship or medical school on addictions. It was kind of a back order type of a thing that people didn't pay much attention to, which is one of the reasons I got attracted to it when I came to Fort Wayne, because not very many people were paying attention to it. And I said, boy, since most of the population has some problem with addictions, I think we ought to pay some attention to it.
Yeah, what about your experience, Phil?
I deal a lot with the alcohol, and when they can't drink alcohol, they will get into other things like marijuana, but because marijuana is a long-lasting drug in the body, they now are looking for other things like the synthetics, trying to skirt drug screens and things like that. But alcohol, yeah, and my experience was that they most often think it's between the ears, that if I can choose to quit anytime I want. And with so many of the drugs, if they don't use it, they don't seem to have any problem, because most of our people are not into the late stage where they're, or middle stage, where they need it and absolutely have to have it or going through withdrawal. Most of our people are still in the early stage where they're just getting their feet wet in terms of the addiction. They know they like it, they know it makes them feel better, but it's not to the point where when they don't use it, they go into significant withdrawal. So they'll end up not using for a period of 2 weeks or 4 weeks, declaring to themselves that I just don't want to use right now. I'm tired of drinking and going out. It's just doesn't appeal to me. And when they don't drink for 2 to 4 weeks, they then get the mindset that they're good to go. Because I can quit anytime I want. I just don't want to now.
You know, I've read that actually intermittent use of a substance is more addictive than daily use. And they did prove that in animal studies. These addictive substances affect the dopamine circuitry, don't they? And no, whether it's alcohol, whether it's cigarette, or gambling, or narcotics, it's the same circuitry, isn't it? These people are missing dopamine in their lives, and they're trying to get the dopamine up just to feel good.
Yeah.
Just to feel good.
The dopamine's a great rush.
Yeah, it's a great rush. Ron, what's the most common thing that you're treating today? And I know you see meth and spice and different things, and are those things increasing? Or?
Yeah, well, that's a good point. I see a different population than Phil here does, because of the fact I do a lot of my work at the hospital. And basically, I see the element of population that's pretty far into heavy abuse. And I don't know if many people realize it, but the reason that we can hospitalize people from detox from alcohol is that before we had the benzodiazepines, 30% of the people who had delirium tremens died. They died of status epilepticus, which basically means they start having a seizure, and no medication known to man at the time could get them out of it. Now with benzodiazepines, we use them because they're cross-addicting with alcohol to basically taper a person off of it.
What drugs do you commonly use? Those benzos that probably you might not totally know. You know what they are. They're tranquilizers. And when people stop the alcohol, they get withdrawal symptoms, which can be seizures and delirium. They get totally mentally out of it, right? And they have to be hospitalized. They're tremor and they're shaking, and a few die, right?
If you go into status epilepticus and you have seizures, you're in danger of dying.
Seizure all the time, and they don't stop, and they're in danger of choking and dying. What drugs, what are common benzos that you run into?
Right. Well, the ones we use for detox are usually Valium, Librium, because they have long half-lives, and we use Ativan as well. But most common ones that you hear of on the street are probably Xanax, very popular. Klonopin has a longer half-life, has good use. Almost all the sleeping pills are benzos, which people don't realize, and work on the GABA system, which is the regulating system in the brain that it affects.
Which the relaxer versus glutamate which alcoholics tend to get, where they just go crazy, and usually that's due to glutamate, right?
Right.
Thank you. Is the alcoholism rate increasing or decreasing, do you think?
It's still very common. I think one point I want to make is just because you drink every day doesn't make you an alcoholic. You may not have consequences from it. The big thing is if you start having consequences from the drinking, then it's a problem. And consequence can be medical, like all of a sudden your liver is showing stress, higher liver enzymes, or you just have macrocytic edema, which means you're not getting enough B12 because the alcohol is suppressing your ability to absorb it, so you're letting out big immature red blood cells from the bone marrow. So once you start getting consequences like that and you don't stop, by gosh, you got problems. The first thing usually that is noticed in terms of alcoholism is the effect on the family. They're the ones that get the first consequences. You know, dad or mom is not there anymore because they're in orbit, because they're looped, you know, type of stuff. And no longer do they feel the affection. And sometimes also abuse comes from it. You know, there's all kinds of drunks, happy drunks, and then there's people who get very violent. And, you know, sometimes they attack their wives, sometimes they attack their kids, sometimes they sexually molest their kids. And with blackouts, a lot of them won't even remember what they did, which is another sad aspect
and a significant number end up in jail, don't they? Because they're
Right.
attacking, you know, family members. Let me ask you a quick question, because a patient asked me this today. I had his wife in here, actually, because she fell down the stairs from alcohol thing. And she has a problem. Then they said their son was also an alcoholic, living in their house. And that was the stress of this was driving the mother crazy, frankly. And they asked me a question: How could my son stay in jail for a year? Not have a drink, not have a drug, and he's out 2 days, and he's out, and he's had counseling the whole time, and he's out drinking 2 days later. What's the answer to that, Ron? That's a puzzling question.
We wish we knew. But the same thing happens. We detox them in the hospital, have a severe detox, and they're in agony and basically all that sort of stuff. They go out, 2 days later they start drinking again.
Even a year later.
Yeah, not everyone, but you know, you get these
Want to give
cases.
that a shot, Teresa?
Well, I'm going to give it a shot, and it just reinforces. You know, Phil said it, that, you know, sometimes they get that thought process, I haven't touched it for a year. We hear that. We have people that are clientele that are in the program, and unless lifestyle changes, mindset changes, then nothing changes. You know, one of the beauties of our program is that we work with people to give them the capacity to start thinking and start making lifestyle changes. However, unless those are realistic and things change in their home and in their environment, and most importantly in their mindset, then they go back to something that's been totally detrimental and has imposed negative consequences.
Our initial treatment is aversion therapy. They get sick, they take a drug called Antabuse, they get sick if they drink on it. It's aversion therapy. There's a lot of places out there that really don't like that style. But for the alcoholic, it seems to be one of the primary ways to do that. They'll get into trouble, they'll come and take the Antabuse, and it's amazing what happens 4 to 8 weeks after they're on the Antabuse and not drinking. Their affect changes, their thinking process changes. They start to get clearer. What they thought was going on before, they now start to see as not the best. And so the Antabuse gives them a chance to kind of step out of themselves for a while to see what was going on, how it was happening. And then to realize that the addiction is not just mental, what goes on between the ears, but it's also physical. So like I said before, a lot of them think that they can will their way into a better life. And that's a piece of it, but the bigger piece is they have to behave themselves into a different
They have to have an epiphany and decide this is what we're going to do. Ron, you were telling me an interesting thing earlier about the Antabuse. Could you repeat that for me?
Right. Antabuse works well when you have a hammer over your head. And basically, I learned about it when I was in the military. And that's what we do with our alcoholics. Basically, we put them on Antabuse, and when the person checked in with his sergeant every day, he got an Antabuse pill, and he better take it because he was ordered to take it. Now, again, AADP are pretty much the clients are people who have 2 or 3 or more DUIs. So they're in trouble with the law, and if they do not comply with the program, they get other consequences. So basically that's the hammer over their heads.
Yeah.
But just for me to prescribe Antabuse to someone coming as an outpatient, that doesn't work.
They feel so miserable that they don't want to. It's very difficult for them to overcome that addiction. They're not going to take the pill.
Well, they'll take it for a while to humor
Yeah.
the doctor, and
Yeah.
then when they decide to drink again, they'll just stop it, and 2 days later start drinking again.
One of the neat things that, I was not a big fan of Antabuse and did a lot of research on it and how it could empower clients, how it can empower people. You do need a hammer, but the beauty that we have with working with these clients is it cleans some of the cobwebs out. If you're not loading your brain with alcohol and keeping it flooded and causing the confusion, it gives them the ability to make more positive lifestyle changes, and that's the beauty of it.
Right. And we knew that from the start, that basically that would be the deterrent, and the person on the Antabuse then would be much more able to get something out of going to a treatment program and learning
Exactly.
on how to not drink again.
Yeah, because the brain has to make a shift. The brain got used to having alcohol or other substance as part of it wrapping around there. Once you remove the alcohol, the brain has to reconfigure itself to learn how to behave substance-free, and that takes a little bit of time.
And there have been genetic neuroplastic changes in your genes, in your dopamine, and I know from looking at MRI scans of alcoholic patients, because they develop blood clots in their head a lot, it's a lot of brain atrophy. Their brain shrinks, so some of it is not repairable. Now my question to you is, have you heard in the literature or seen that people who are addicted to narcotics, say for many years, and they don't use alcohol? I was reading a man who does a lot of SPECT scans, and that actually with opioids, the brain shrinks too. The brain shrinks. I was not aware, and I've not seen scans yet, where you see the tremendous atrophy, brain shrinkage that alcoholics get. So there's a point to return to normal. It's very difficult, because in this addictive dopamine circuitry, there have been some permanent changes. Some receptor sites have died out, and it's hard to get them to work again, and it's difficult for some people to get back to normal.
Even in AA, it was always known that recovery takes a long time and
Yeah.
years, and it takes that long for the brain to recover from all these changes. Yes. The other thing that came to my mind that we haven't touched on is that the tendency to have problem with alcohol is inherited. There have been a lot of studies that basically pointed out that it runs in families, and there seems to be 2 kinds. The more serious kind, or the more devastating, is the one that goes from father to son. Those cases, usually the kids get into trouble when they're 12, 13 years old already, and basically by the time they're adults, they have a police record. But what seems to happen, it's passed through heredity, is that these people have a tolerance for alcohol, and they can drink other people under the table. When I go out and I have 2 drinks, my speech gets a little bit slurred. They don't have that advantage. Basically it doesn't get slurred, and they don't have any sign of intoxication until their 5th, 6th, or 7th drink. And then, all the circuits are disrupted in the brain, and they have blackouts, they don't remember what the heck happened, etc. So, that's another dynamic that I'm not sure everyone realizes, but there is a tendency of not being able to handle alcohol well at all. And some cultures are not, I shouldn't say cultures, but races actually have a protection. Like the Japanese, I understand that they have kind of a built-in Antabuse system. And after a couple of drinks, they basically have a negative reaction, which cuts down their rate of alcoholism.
Maybe it doesn't work for sake. Huh? It's, I think, a very interesting point that you make. We were discussing earlier about meth, and Phil, could you tell us about some of the patients you've been following with meth? And you brought some pictures with you about the tremendous effects that meth has. That people's teeth fall out, Their appearance changes tremendously, and you have some pictures. Could you speak about that a little bit and show us the pictures?
Meth is an amphetamine, so it's a speed. And this is one of those that really the brain seems to love it. So it chases after it. So in a very short amount of time, people can have a lot of problems. For example, there's one that we showed a picture where a guy 4 months into using. And these are what has happened is this particular police department has identified people that they had booked before, and they're coming back to be booked again, and they're noticing a huge change in their appearance. And the first picture shows the guy who was 4 months into meth use. He's starting to show a sunken cheeks and a slender face. He's losing weight because as an amphetamine or speed, they tend not to eat. It speeds up the metabolism, and they're just on their way. The next picture shows a young lady who is 8 months after meth use, and you can see where her eyes are starting to be sunken. She's showing a definite change of appearance in this way. Now, meth, again, was typically used in the country, so Noble County and some of the northern counties of Indiana are more susceptible because meth, when you make it, has an awful odor. And if you did it in the city, it could be found. Now they did it more in the country where it was the open air would allow it to be
I didn't
made.
know that. That's the reason.
Now they've found that they could do these little one bottle deals where they can shake it in a 2-liter bottle, and so you're seeing it become more prevalent around. The next picture showed a young lady who, after a year and a half, now she's looking withdrawn and starting to show outward sores because the meth, I mean, it's a combination of fertilizers and battery acids and whatever in the mix of this stuff, and they're inhaling it deep into their lungs, and it's getting into their skin, and they scratch, and it causes sores and all that kind of stuff.
Yeah, dramatic effects. A lot of young people are using it. You see, the appearance is just destroyed.
Yeah. Now they don't even think about it. Now again, there's some vomiting going along with this kind of stuff, and I don't have any pictures of that, but it will rot the teeth. The stomach acids will start to rot the teeth, and they fall out. And you would think that my gosh, wouldn't they see this and want to quit? It's like no, their senses are overridden by the need or the desire for the dopamine reaction.
The dopamine is so low, and I like to remind the audience right now that I almost sometimes, except for the initial decision, I think the addicts cannot help it. And addiction, mother doesn't matter, father doesn't matter, brothers and sisters don't matter, society doesn't matter, religion doesn't matter. There's only one thing that interests the addict, the fix. That's all. That's why we're here tonight, because they have no control. And meth gives you such a tremendous high of dopamine so quickly, and it's a highly stimulating drug, and that's the reason people do it. We have to find different ways to make people feel good. Yes. But once they started this, very hard for them to make the decision to quit because they're so low down, so low, they just want to have a day where they feel decent.
Correct.
And while they're doing it, they're killing themselves.
Yes.
And I appreciate you bringing up that point, Dr. Cashman, because as I hear working with our individuals, keeping your addiction alive becomes your full-time job. It is your top priority. Nothing else matters. And we have people that are at a point that they can't change that lifestyle. They need intervention to assist them with that process.
Right, to throw them in jail has no value, and occasionally you have to do it, but I think it's little value. They need counseling.
Yes, but sometimes we deal with probation all the time, and we see the value of at least that interruption. They get thrown in jail for a couple of days.
Tell us the benefits. So,
a couple of days. We
Yeah.
think that jail can be therapeutic.
Yes.
Okay.
That it interrupts them. It says there are consequences.
Okay.
You can't just willy-nilly do this, because a lot of people, like we've been talking about, they believe it's a cognitive function to quit.
Yeah.
To use. They choose to use because they choose to use. And I'm saying there's also the behavioral piece of it as well, and that they use because of an emotional stance.
Yes.
They use because it feels good. It's emotional, not logical. No one would do this from a base of logic or reason.
Yeah. Yeah.
The other nice thing about jail is it's very unlikely they're going to get the substance while they're in the jail.
Yeah.
You know, and it really helps
Yeah.
the
It's
mind
detox.
get
It's detox.
it's detox, right?
Uh-huh.
And it's amazing how many of them do that without any sort of help with other
Yeah.
medications. I mean, they just do it cold turkey so forth, and recover. Really, with opiates and with the amphetamines, they're not dangerous to go off of them. It's only the alcohol and the benzodiazepines that'll kill you on detox.
I see.
So the rest of these people can detox in jail very safely.
They feel like they're going to die.
Is that right?
They won't.
Yeah,
And they want to die,
Yeah.
but
Because
it's very
it's
uncomfortable.
horrible.
It's
Yeah.
horrible,
Right.
the symptoms and the withdrawal symptoms. But
But
I
they-
appreciate you
Yeah.
substantiating that.
Yes, and so there's a couple other pictures. There's a 2.5-year person on it.
That's very well worth seeing.
Yes,
Yeah.
a 5-year or a 4-year
Oh, boy.
Let me
picture.
make a comment on that, but
Yeah.
look at the aging
yeah.
in that picture. You know, this,
Yeah.
this is a young lady that looks now like she's 60.
25 to 60.
Yeah,
Yeah,
exactly.
4
You
years.
know, that's what
Yeah.
they're doing to themselves, and they can't stop.
No.
That's
No,
the
it's
sad part of
2.5
it.
years, yeah.
Yeah.
And then the final picture was a gentleman who was at 4 years, and just how he looks completely different.
Right.
Tell us a little bit about the shortage of facilities in treating these psychiatric cases. You know, it appears to me medicine as a physician, they've always taken psychiatry and kind of pushed it off to the side. But I tell you, my experience of 42 years, the majority, what I look at, 70% of what I look at in some way is attached to the mind. And to me, it really should be the biggest field, not the smallest field. Personally, I mean, what I think we need is a lot more facilities. We can farms or something where we detox people for a month, and then through psychotherapy, you know, for a few months, try to get them back to normal. But I do understand the addictive process for most things is there for a lifetime. Let's hear your comments on that.
Well, one of the ironies that occurs now is that most of the treatment for substance abuse, you have to get in trouble with the law to get a long-term program. The long-term program up here in Northeast Indiana is the Kelly House. And basically there you have to stay 6 months in a treatment program that I think is going to be proving to be very successful. But we're fortunate actually in Fort Wayne. We've always had halfway houses. We always had treatment facilities. The worst thing that's happening is that insurance doesn't want to pay for long-term programs. And while that's fine for, say, 85% of the clients that we see, there's that 15% that need something long-term, and it's very hard to afford. In fact, most people can't afford it. But if you get into trouble with the law, fortunately in Fort Wayne, Indiana, we've got a good probation system, a good legal system. Judges favor rehabilitation rather than keeping in jail, and by gosh, we have a pretty good system. But always it could be improved.
Now, how you treat people too, in terms of, as you're saying, if you get into a treatment program, an IOP, intensive outpatient program, it's time limited. You have to get so much crammed into a short time, and people aren't always done getting what they need or getting their recovery into play in, say, a 12-week period or an 18-week
Yeah.
period. That's another problem, where we're kind of strapped with that, and if we can open it up a bit. Now, now a lot of therapists are coming out and declaring that cognitive behavioral is an approach. A lot of people are suggesting that most addicted people also have underlying traumas in their life
Yeah.
that have never been
Yeah.
addressed. Not that I want to assume that people are self-medicating. I really don't like that term personally, but in certain cases it is true.
Yeah.
Okay, but I don't want someone just coming up and saying, well, I'm self-medicating, so I'm doing a pound of pot a day.
Yeah.
Okay,
And then moved to some research on alcoholism years ago. When I went through med school, it was assumed that people that got into trouble with alcohol and drugs had some sort of a personality disorder. In other words, their thinking was all screwed up, and they basically didn't care much about people, blah, 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 blah. Well, there was intensive study on the East Coast about this issue, and they did psychological testing on people, interviews, before they even saw any sort of a drug, and then followed them through adolescence and into adulthood. And what they found is that most of them had perfectly normal psychological tests until they started using booze and other substances. Then they started mimicking virtually every psychiatric condition in the DSM-4 or 5, wherever we are at this point in time. So that's another thing we haven't said, that when you use these substances, they mimic other mental illnesses. And I get people in the hospital all the time that have been diagnosed schizophrenic or bipolar, and they don't have the affliction at all, but they were using substances that basically got them psychotic.
I see.
Many
Very
times when
interesting.
we're
Yeah.
doing our evaluations with our clientele, they're talking about depression. I'm bipolar. You know, the addiction takes on so many faces and personalities with an individual. They become self-centered and they exhibit antisocial traits, narcissistic, self-absorbed. And you take that individual before the addiction came in, and some of those things never existed. It's what the chemical, the substance it does to the brain chemistry. And if you watch and follow this individual 30 to 60 days down the road, some of these characteristics don't exist. Do we reevaluate and look at individuals who might be suffering from depression? Yes, but you can't make a successful evaluation if you don't have the substances out of their system. It's a constant evaluation. Do some of these people have depression, bipolar? Yes, but that's something where the chemicals are out of the system to make an adequate diagnosis.
Right.
You know, it only makes sense when you think about it. I mean, schizophrenia, depression, these are chemical illnesses, aren't they? And that the alcohol or the nicotine or the opioid change your brain through epigenetics and through neuroplasticity, and they can mimic all these psychiatric disorders.
Absolutely.
But if you could correct the addictive system, they could get rid of these illnesses. That's really, neurochemistry is just fascinating. And what's the most addictive substance there is?
That's an unanswerable question.
Well, I just put it on the table and we could talk about it for an hour. I say it's food.
Okay.
It's food. I've debated people on that before, and some people I think so, because you got to eat. It's a substance you can't get away from.
Okay.
There's always a little humor in here.
Thanks.
Well, look like you don't have any trouble with it. I do. I like my desserts.
Yeah, on the subject of mimicking illnesses, it brought to mind a lady that I've taken care of at Parkview Behavioral recently. But she came in some months ago, and at that point, she tested positive for spice. And basically, she was diagnosed as a delirium secondary to spice. Well, she came in this time, and I was absolutely convinced that she was schizophrenic. She had all the signs and symptoms of classic schizophrenia, and I basically put her on an antipsychotic medication to keep her in remission. However, when her testing came back 3 weeks later, she was positive for spice again, but she wouldn't admit it, and basically, you know, we thought she basically had she was really schizophrenic, and that we're treating her for the wrong condition. So I think a lot of that happens because, as we were saying, these drug abusers, their symptoms can mimic any psychiatric disease there is.
And I understand, because the child's brain is not fully developed till age 25 or so, that I was reading that if a child smokes and uses alcohol, which changes the neurochemistry of the brain, the odds of becoming an addict runs around 80%. Is that true?
I would agree with that. I would agree with that.
Are you seeing a lot of kids, teenagers?
We don't. We deal with adults.
Okay.
Now, we do have kids come in sometimes because their parents or places want drug screens, and we will do drug screens on kids, but we don't see a lot of it
Yeah.
because that's just not our population.
One drug that we haven't said much about is cocaine,
Yeah.
which also I think is worth mentioning.
Absolutely.
I hear less about it for some reason at this point of time than I did some years ago. But cocaine's interesting in as much as it also can cause extreme damage to your body and to your brain. It causes a constriction of arteries. And basically, if that happens in your heart, you can have a heart attack. If it happens in the brain, you can have a stroke. Those that snort it oftentimes snort it so the arteries in the nose start clamping down, and then pretty soon they have no septum, because basically that's all dead tissue. And
So if you have a child whose teeth are falling out and his nose isn't looking right, you got to be suspicious, right?
yeah, well, again, just looking at the outside of the nose, you won't pick that up. You have to look inside, and the
Inside.
fact that the septum is gone. But again, it's an interesting disease. I mean, it's an atypical addiction in which there's a long withdrawal, but after you use it steadily and then stop using it, there's a crash. And these people virtually can't get out of bed. I mean, they're so wiped out and they're exhausted.
Yeah.
And again, it's not a dangerous withdrawal.
Yeah.
The danger is in using it, that you don't get a stroke or a heart attack that's going to kill you or cripple you for life.
Yeah, I heard it's a dopamine rush stimulant, a tremendous stimulant of the receptors, similar to meth.
Right.
And you don't you wonder what the changes you see in the meth people, that it's vascular, a lot of it is vascular, it destroys the vasculature to the teeth, the vasculature to the skin. You see the aging process, puts it in spasm, just like an advanced smoker. You know, it's like you get the changes you see in smokers 20 years later, you got it here in a couple of years, or maybe even months. I'd like to spend a minute discussing the epidemic that we're seeing around here of patients being addicted by prescription narcotics. I mean, it's across the nation. This year, so far, 18,000 people have died from a narcotic prescription. 109,000 in 10 years, right out of the literature. It's a huge thing around here, and a very significant, problem to the point that people ought to be very careful accepting, a prescription, especially, say, a young woman. Why? She could become pregnant. In West Virginia, 10% of the babies born right now are addicted. They have to put on methadone or morphine to withdraw them. 10%. We see it in Fort Wayne. I've seen it. I've looked at the statistics at the hospital. I asked the intensive care nurse physicians and nurses for the stats, and they've given it to me. It's present in this community. But in West Virginia, it's 10%, and ours is rising. So if you hand a narcotic for no good reason, say to a young woman, just for backache or neck ache, unless they have a ruptured disc or whatever, a broken leg or something, you got to be very careful, because suppose you get pregnant, and then you've got an addicted infant, which can affect the infant, for a lifetime. Now, I take another minute to discuss the problem that I'm personally dealing with a great deal, and trying to change the way we treat pain. I'm a neurosurgeon, I treat pain all day long. And to me, I think what we're doing in the medical community is not carefully diagnosing the situation. We're handing narcotics to people who have not a clear diagnosis. I think as the biggest group of people, so I made up a name for them. What do you call these patients? Idiopathic pain? Who wants to be an idiot? Pathetic. So I don't like the term. So I made a term called metabolic pain. Call them the M people. You could call them the Coke people. I talked to a doctor at Lutherans today, and in the hospice, excellent physician. He said in their literature they call it total pain, but that seems a little insulting. I like to keep it metabolic pain. So if I get a phone call from a doctor or the emergency room and say, I have a patient here with metabolic pain, they hurt, but I don't know why they hurt. It's my opinion, and I'd like your opinion. To me, those people should not be given opioids, morphine, or benzos, because you can get addicted to those too, right? To me, I don't think these should be prescribed. That would then take care of about 50% of the pain people, and the addiction rate could way down, because to me, prevention is the big thing. Once you're addicted, and you might all throw in what percentage you think odds of curing the patient. To me, what I'm familiar with and have read is it's not very high. But what do you think of this idea of mine about the metabolic pain thing, about calling them something?
Well, and I think for me, the population I've dealt with, people that have dealt with opioid addiction, Unfortunately, many of them started out with a prescription to address pain and found themselves, because of their brain chemistry, are talking about they like the effect. And I guess what I'd like to throw out is we were talking about addiction. If pain medication makes you feel real good or gives you abilities or thought processes that you could do something differently, then the pain medication is not doing what it's supposed to do. It's to address the pain on a short-term level. Many of these folks got prescriptions and took them and began liking them, and they can't get off. And a lot of people say, well, why don't they just stop taking it? They can't, because the withdrawals, the pain factor, the emotional, without some assistance.
And they don't feel good. They're so low, they don't feel good.
They don't feel good.
Unless they get the memory back of that dopamine. Ron, what do you think?
Well, again, I think people don't realize how addicting these substances are. And they have the misconception that if they get a prescription for this and they follow the prescription, they're not going to get addicted.
Yes.
But
Yeah.
they're still going to get addicted because you take the thing on a regular basis, you're going to get addicted. And of course, those that enjoy the effects of the medication, they're going to be inclined to take more and more and more, and then getting into trouble with it. So
Yeah.
that's one of my concerns
Yeah,
about
doctor
the whole
does
thing.
say, Dr. Cashman, I'm not addicted, but will you please refill my prescription?
Right.
And then if you don't refill it, you're in a heck of a fight.
Correct.
And,
Now-
and,
One thing that I did learn in my medical training is that opiates are not good for chronic pain. And that's where I
Yeah.
think that basically is what you're calling your metabolic
yes,
pain.
yes.
You know, stuff like fibromyalgia and so forth, that's being diagnosed much more commonly now.
Yeah.
I see people being prescribed the opiates, and it doesn't do that much good. I saw a chart of a gentleman who went to a pain clinic, and he went there for years, and never did his pain get any less than 10, the maximum. They just kept upping and upping and upping and upping the opiate, and basically no relief. You know, so you get hooked on this stuff, and then what do? You know,
Now you
have
have
to
another
keep-
disease
Right.
called chronic pain.
Right.
You not only had the fibromyalgia, now you have disease too, chronic pain. And it's a heck of
and
a problem
addictive.
now.
And addictions.
Yeah. Fibromyalgia doesn't kill people, and
Right.
and now you're addicted. I completely agree with what you say.
Yeah, and then how do you
think?
deal with it,
Yeah.
though? How do you deal with it?
Yeah,
Because
how
you
do
go
you
to a
deal-
doctor
how do you deal
who
with it then?
prescribes you.
Yeah.
Once the doctor realizes your tolerance is up and you
Yeah.
no longer are eligible for their services because they know now that you're misusing the drug,
Yeah,
they cut you off.
yeah.
It feels so horrible to be off of it. People
Right.
oftentimes go out to the streets
And commit a crime.
and commit a crime or get it off the streets, pay for it, and,
Yeah.
and now they've got their own cycle going.
Now you can see my passion, for prevention. To me,
Yeah.
prevention is extremely important. And I've read different rates of once you're addicted. What are the odds of getting off the thing? What do you think?
Wow.
Yeah, it's just
that-
a guess.
It's not
I mean,
good.
none of us know.
It
7.
used to be
7%.
7% or 3 to 5. I think it's gone up. Some society, our nation has done a good job with education. I think it might be 7 to 8%. That's a
not good.
real low number.
See, I was,
Now we're talking about
that's
which
exactly where I was
addiction.
at, 5 to 10.
We're talking about opiates?
Yeah,
Yeah.
and you would agree with that. That's mine.
I haven't heard
I was
anything
reading
different.
a book, where he thinks it's 90%. I think he's selling books. I think he's selling books. And what about, I've written quite a few books on proper eating, because this is what I see in the office a lot, type 2 diabetes, and is teaching the patients with the addictive process proper diet very important?
In working with clients, you have to look at the whole life spheres. It's a balance. Addiction is about it balancing your life and getting it back on it, where it's spiritual, where it's family life, where it's work life. Nutrition is a key component. Many of these individuals, you looked at the pictures. People would rather starve. They'd rather get high and starve. Their nutrition fails is getting them to do proper diet, proper exercise, and a lot of those things in their brain chemistry start to heal. So that's a big component of what we look at.
The assault of addiction of the drug depletes the body of nutrition. obviously, in my mind.
Yeah.
And so when you quit the drug, the nutrition becomes absolutely important to get your balance back.
Yeah, thank you for saying that. Ron, any thoughts on that? And,
No,
as he would,
nothing different than has been
I think
said.
we'll all generally agree that and I've wrote a book called The Secret of the Non-Diet. Not a diet, it's nutrient-dense eating. And I could imagine in the addictive process to get those nutrients inside of you, the phytochemicals of these nutrients are extremely important. So I think our focus, I think of all four of us here, our focus really is prevention. Prevention. Right. Don't accept that opiate script for just a neck pain or low back pain. And you mentioned, Ron, too, for migraine headaches, for example, for which you had told me that it should not give a narcotic. We see a lot of patients with migraine headaches, which is interesting enough. I was sort of studying that subject a little bit, and half a book I've written on it. So I found it to be a fascinating subject because it's about neurotransmitters. That's what migraine headaches are all about. And I'm thinking, it's a hypersensitive brain, and dopamine they speak about, the waves of serotonin and dopamine coming across the brain. That's the migraine headache. Fibromyalgia, some doctors don't even believe in it, but I've been at this 42 years, and I believe in it. And if people have sensitive skin and they have sensitive muscles and trigger points, and what does that come from? The sensitized, hyperactive brain that's the same in migraine headaches. That's what they got. They have this very sensitive brain cells that they can inherit or stress or whatever. But fibromyalgia, I think is the same darn thing. I think it's a relative of that. And why else would you have these sore muscles and stuff? It's an impulse from the brain and the neurotransmitters that do that. I think I'm right about it. I don't see that in the literature anywhere, but I think it's an interesting concept. I think it's a real entity. And narcotics should not be used for migraines. They should not be used for fibromyalgia because then now you got two diseases. Now you got chronic pain, you got migraines, and you got fibromyalgia, and you're a chronic pain person. And I would say, to be perfectly honest with you, I think we all providers don't quite know who to give an opioid to, but I think we're starting to get the idea through state laws and education. But I would say at least 50% of the pain centers concern me a great deal. And I've seen abuse of an unbelievable nature. It's very dangerous to me to go to a lot of pain centers. First thing you want to do is stick a needle in you. Don't talk to you. Don't take a good history. You must take a thorough psychiatric history before instituting opioid therapy. And you ought to try complementary medicines from exercise to a great massage. Massage is underused. Acupuncture, biofeedback, sometimes psychotherapy should be used before here's your OxyContin, here's your fentanyl. The pain centers started around in the 80s, and a lot of us really was promoted because of OxyContin. And there was a company called Purdue Frederick. I don't mind saying it. I read that history. And they sent salesmen all over the country. And they had very good public speakers. Dr. Portnoy and from the Sloan Kettering Institute, excellent speaker, went throughout the country, told everybody how great this drug was, how you could use it for non-malignant pain. And it was everywhere, and they addicted a lot of people. As a matter of fact, Purdue Frederick was fined $800,000 by the federal government for not being truthful about the addictive potential of these drugs. Wow. I know this history. And then that was the birth of the pain centers, and now they're all over the nation, from pill mills to regular pain centers. Certainly there's some good ones. There's some good ones in town here, but you have to be very careful, because this can start the process. So don't take a narcotic for neck pain or low back pain or light headache. You got to have a broken leg. You got to have cancer. You got to have a good reason.
One thing I wanted to bring up and forgot, but the mixing of opiates and benzos can lead to death, and I don't think a lot of people realize that. And not only death, it can lead to hallucinations and so forth. Right? I learned that personally because when my wife had third-degree burns and she was placed on opiates, they gave her Ambien on top of it, and basically she had visual hallucinations and auditory hallucinations. She was aware, and she told the staff about it. They cut out the medicines, but you know, again, that combination is particularly dangerous, and I want the public to be aware of that.
Yeah, thank you. Teresa, could you expand on that?
Not much. Dr. Panzer said it all, because many of our clientele do the mixing, and I refer to him as Sid the Science Guy. They're constantly, you know, investigating the internet and mixing chemicals to get this high. You know, we're looking at cannabis. Cannabis is used a lot with opiates, so I can't say any more than what Dr. Panzer said. It's a very lethal combination. Lots of overdoses with it.
Yeah.
Yeah.
Phil, any thoughts on that?
Well, yeah, I just reminded of Anna Nicole Smith's son.
Yeah.
When he died, they said that he had methadone in his system and a benzodiazepine, but we don't know why he died. Most everyone who's associated with drugs
Yeah.
knew why he died.
Respiratory arrest.
Yeah, because he overdid it. He overdid the one and the other, and it shut his system down.
Yeah, they all affect the respiratory center at the brain stem, and especially dangerous in patients with sleep apnea to begin with. You know, there's sleep apnea to begin with, but there's also these drugs affect the central breathing mechanism in the brain stem, shut it off, and they just don't wake up. And I warn the patient on these things to get into treatment quickly, like a patient I saw today, and on 4 or 5 different medications. I sent him into rehab. I said, I don't know if you're going to wake up tomorrow or not, but no one ever supposedly, you know, had told him that. You know, very dangerous situation. So I think, and tell us a little more about AADP. What's going over there? What do you?
Well, it started about 25, 30 years ago as a deterrent, because people used to get arrested for OWI, put in jail, arraigned the next morning, and then they would oftentimes given a bond, they paid it, and were left to go, and then to return to court 3 to 6 months later.
Yeah.
That was standard procedure.
Yeah.
And then about 25 years ago, 30 years ago, they did the same thing, normal stuff, but the guy, when he was let go, paid bail and got out, within the week, drank again, drove, this time people were killed.
Yeah.
And the court system said this is not acceptable.
Yeah.
And then the study, there was a comment about ant abuse. They went and looked at it, took a couple years actually to study it, how the legal system could get wrapped up in it.
Yeah.
And so we now deal with felony level OWI offenders.
Mm-hmm.
Our program is 100% funded by the generous donations of our clients. Not so willfully, but yes, the generous donations of our clients pay for their services. They got in trouble, they pay for it.
Yeah.
We get no tax money, no grants, no
Is that
nothing.
right?
Yes.
Seems almost shameful. You think, you know, we're going to spend a little money, government money. That'd be a great place.
But the thing is,
But it doesn't take tax dollars.
it doesn't have to take tax dollars. This is absolutely
Okay, that's great.
self-sufficient.
Yes.
That's
You know,
great. Okay.
Statistically, and I've worked with grants. I've written grants, and have had the opportunity to see when people get something for nothing.
Yeah.
If you don't have an investment in it and you don't take responsibility, it doesn't work as well.
Oh, I'm so glad we touched that subject.
Yeah,
Makes it
actually,
very clear in my mind. Yeah.
Yeah, there's
Yeah.
studies proving this fact that you
Yeah.
do much better charging something rather than giving it for free when it comes to therapy.
There's some investment there.
Yes.
Yeah.
You know, prior to AADP, these people were sent to jail, and the sentence was something like 3 years.
Yeah.
Well, you know, what happens then? Well, this family is without a bread earner,
Yeah.
and basically often they go on welfare
Yeah.
or something for some sort of support. This
Yeah.
guy goes in jail, gets absolutely no treatment other than being dried out.
Yeah.
So it comes out and does the same thing. So Judge Ryan, I think, was probably the
pioneer,
gentleman,
huh?
the pioneer that had this idea, and then got a group of professionals in the community to form this agency.
Yeah, my memory of from years ago, actually, is your name was attached to it, and then Judge Ryan is a wonderful memory. And then now you're all working there, this
Yes.
wonderful organization which I promised to join and help in
And
any way
we do have
that
to,
I can.
We do have to mention that Judge Phelps, because the sitting judge has the opportunity to keep it or disregard the program, and he has let us know that he's okay with what we're doing right now. That
Well,
things
we
are
know
going
who
well.
we're going to vote for in the next election,
So
don't
yeah,
we?
Judge Phelps
Yeah.
is
Judge
a great
Phelps.
component for us
Yeah.
as well.
Yeah. So let's summarize our wonderful talk here a little bit. And what is there any general advice, Teresa, that you would say for people to avoid the addictive process? I know some of it seems obvious, but what are your little pearls, Teresa?
I think is to get as much education as possible. I mean, to view these opportunities, to take the opportunity to call people in the community. But one thing I would like to say very much is that people need to take care of things in their household, become aware. Try to get as much education. If you're on prescription medications, put a safe hold on that.
That's a big one. Lock it up so that you don't have a teenager, taking your stuff or a relative or anything like that. Ron, what are your thoughts?
Well, I don't know what to add. The frightening thing is that it's a problem that's growing, particularly with these opiates. And I don't know what the end of it is going to be. Certainly, we've learned that trying to control this thing legally doesn't work. I mean, we had a war on drugs now for how many years, how many billions of
What a waste
dollars
of money.
have been wasted trying
yeah.
to combat the situation that way.
To do the work in Mexico is ridiculous. It should be right here.
Yeah, and what we basically have created in Mexico is a bunch of gangsters that have very sophisticated ways of getting around the customs and everything.
Yeah. Phil, any final words you got?
Supply and demand.
Yeah.
If you don't have a demand, the supply doesn't matter.
Yeah. Yeah.
So-
I've always felt that we should work on this end, educate people, not to demand it. The supply is always going to be there because there's a lot of money. The government is wasting a lot of money there. They should provide it for treatment. So I think in summary, we have a number of programs we've had now on the addictive process. We taught you the physiology, the anatomy, and now 130 years of experience sitting here putting it all together. Please join us in this fight. If there's something interests you, let us know. Send me books to read. Send us letters. We're willing to work together to improve this community. It's frankly, you can see here, we love the patients out there. We love the patients out there, and we like to. Prevention is the key. Prevention is the key. Well, thank you very much for appearing in our show tonight. Teresa, thank you very much, Ron.
Yep.
We're going to do this again. I've had a lot of fun here tonight.
I've had fun.
So we're going to do this again. Thank you very much. And listen to our programs, our mind-body programs. Call me Dr. Wellness, Dr. Cashman. Dr. Second Opinion would be okay too. I work on all aspects of trying to get people well through lectures, books, DVDs. Look at our website, CashmanMindBody.com or Amazon Books. You'll see my stuff. And all about education. I'm an educator. Physician means teacher. It means teacher. And that's what we're trying to do. Thanks so much. We love you all. Namaste.